So today we're going to be talking about cortical visual impairment. I prefer this term over cortical blindness because the patients don't have to actually be blind. They can just be visually impaired. So cortical visual impairment means they're impaired with their vision because of a problem in the occipital cortex. Now, it can be that it's cerebral visual impairment because it can be the radiations. It doesn't have to be the occipital cortex. But in general, when you have lesions in your brain, because the crossing point is the chiasm, any lesion behind the optic chiasm body is going to produce a homonymous hemianopsia on the contralateral sides of the lesion. So normally when you have a hemispheric lesion, for example, in this patient who has a right homonymous hemianopsia, you're going to have something that is damaged, either the retrochiasmal pathway in the temporal lobe, parietal lobe, or occipital lobe, and that's going to be on the left side. And so when people have a homonymous hemianopsia, they still have normal acuity because they still have half a macula. The half on the left is still able to see 20/20, even though you've lost everything to the right. But when people have cortical visual impairment, they have a lesion that's on the left side, so this is like the MRI, and they have a new lesion on the right side. So when you have that happen, you have a left homonymous hemianopsia from the right-sided lesion superimposed on the right homonymous hemianopsia from the left-sided lesion. And so when we have a cortical blindness, you actually have bilateral lesions. So that can occur from bilateral simultaneous stroke or sequential stroke. You had a stroke in the left occipital cortex last year, and now you have a new stroke in your right, and that juxtaposed homonymous creates cortical visual impairment. But sometimes it's not a stroke, it might even be reversible, and so one of those conditions is called the posterior reversible encephalopathy syndrome, usually from hypertension, but also from pregnancy, eclampsia, or meds. And in those patients, they have bilateral posterior cortical disease, usually occipital, and that white matter change and edema can be reversible if it's vasogenic edema rather than cytotoxic edema. So it can be a stroke, it can be press, it could be seizure, it could be a tumor, it could be metastatic lesions. So it really doesn't tell you what the cause is when you have cortical visual impairment. And the way to make the diagnosis is the visual acuity is down, and it'll be down in both eyes equally. They should both be affected the same. It could be 2200, it could be hand motions, it could be no light perception. But the pupil better be normal because a cortical retrochiasmal pathway does not contain the pupil pathway. And of course the rest of the exam in the eye is going to be normal because it's not really an eye thing. So the slit lamp, the pressure, the motility, and the fundus exam all have to be normal. And that's what makes it dangerous, because you have patients who have loss of central vision, they have a juxtaposed homonymous, so you really can't do the field on them, or if you did do a field, it's a juxtaposed field, and the rest of their eye exam is normal. And you might think this person is faking when they actually have cortical visual impairment. The reason you might think they're faking is because their pupil is normal. And so you really should be thinking in the differential diagnosis of bilateral simultaneous loss of vision with a normal pupil and normal eye exam, that maybe the reason the eye exam is normal is because it's not an eye thing at all, and it might be cortical visual